Hello to all. I really wish you're having a good time in Belgium. I would like to apologize for not being able to be with you guys in person. And I would like to deeply thank the executive board of the IFCC and more especially Professor Osborne for letting me participate remotely to this important session. I'm thrilled to be able to share with you guys the work we're doing in the working group on laboratory errors and patient safety of the IFCC. I have to confess that I found it quite challenging to record my presentation because, it's always possible to start again and be better. And this is actually the second version that I'm sending to the IFCC office because I decided to introduce the subject of patient safety in a different way of what I'm doing usually. I would like to share with you guys that over the last months, I had to support my wife that went through multiple treatments and that needed multiple blood tests. So for the very first time, actually, I was able to see how it is on the other side of the fence when lab tests are needed, and also the impact of laboratory problems and sample rejection. And I think that too often we are thinking about patient safety and quality, focusing too much on the tubes. This is what we see in our lab, right? And we also have like such a huge increase of tubes that we can well manage with the automation, but still, I think it's getting tougher and tougher to keep patients in our mind. We can have very important potential consequence for patients when it comes to laboratory errors, delayed in diagnosis and treatment, inappropriate treatment, impact on quality of life and increase mortality with bad results, unnecessary procedure and retesting, doing the blood draw again, extended hospital stays and higher cost, and also at the end, potentially loss of a patient trust. So how can we address this? And before moving forward and sharing the work we're doing in the WG-LEPS, I thought it was a good strategy to take the numbers we have in the WG-LEPS and to show you the importance of the problem. So this is a publication we published a few years ago, and this is the rate of errors for different pre-analytical errors that we're facing in our labs. And so this is real statistics from multiple labs across the world. And I took actually the 50th percentile of these rate of errors, and I calculated the number of adverse events and a sample rejection, considering I'm managing 2 million samples in my lab right now. And if you do the addition, look at this, at the end of the year and each year, it's potentially more than 34,000 errors and leading potentially to 34,000 sample rejections. Look around you, look in the room, all the lab director, and do the addition of all our labs together, how many impact for patient. Only for my lab, I could actually fill up a football stadium with all these patients. A Canadian football stadium, because I know that stadiums in Europe are quite big. You get my point, right? So let's try to find a way to reduce all these laboratory errors and putting patients in the center of the equation. I like this slide because for me, it describes really well the challenge and the problem we're facing right now. We're all aware about the fact that most of errors are at the pre-analytics and the post-analytical phase. Professor Plebani was really good promoting this in the last 2 decades. Less than 10 to 15% of laboratory errors are at the analytical phase. We're running thousands of internal QCs, having external AQA program for every test we're running in the lab. We're putting a lot of time and energy for the quality of the analytical phase, and it pays off. It explains why the rate is so low. However, right now, most of errors are in the pre-analytic, post-analytical phase and are related to lab processes. And how can we address this? How can we monitor our processes and improve the quality? It's with quality indicators. And as you know, this is the priority of the WG-LEPS. So I think that over the last decades, the working group was quite successful providing clear guidance and recommendation for standardization of quality improvement and standardization of quality indicators in laboratory medicine. And I would like to acknowledge the work of all the members and corresponding members, more especially Professor Plebani and Siakovili, that were the past chair of this working group. But beside this, there's still one challenge remaining. It's the limited participations of laboratories across the world in the quality indicators comparison program. And for me, it makes no sense at all. We're all participating in the AQA programs for our analysis, and we know that most of errors are in our processes. So we need to be able to participate in these programs and know exactly what's a good or need to improve performance and improve all together. Discussing with our participants and brainstorming within the working group, we know exactly what's the problem. First of all, the number of quality indicators in the IFCC program is too excessive, and so it's difficult to manage, and we agree on this. Secondly, it's quite challenging to access data for a lot of laboratories and for specific quality indicators as well. So we decided to organize a third consensus meeting of the WG-LEPS last year in Quebec, Canada, to address these important issues. And super proud to tell you that we had experts coming from all over the world. Some of them were there in person, others were attending in virtual, and we were able to focus in a full 2 days meeting to address these important challenges. This consensus group was hosted by the Canadian Society of Clinical Chemists and the Quebec Society of Clinical Biology, with a strong support from the IFCC as well as the VLP lecture program, and supported as well by Siemens Healthineers and Abbott to be able to cover all the fees with the experts' transportation. So our first objectives and what we were able to solve is to be able to select a smaller set of essential quality indicators to maximize participation and improve patient safety. We wanted to have a short panel of quality indicators that were covering the total testing process. And so we were able to discuss this thoroughly within the working group members and do a good analysis of all the data we have in the IFCC program, looking at the capacity of detection by our users, participation, the rate of the errors, and more importantly, the potential outcome and consequence for patients when these errors occur. We were able to come up with a nice panel of 6 QI: rate of patient misidentification, the rate of hemolysis for a quality of blood sampling, the rate of sample rejection, to have an overview and direct view of the impact for patient, including all the different pre-analytical QIs leading to sample rejection. We also have at the analytical phase the rate of unacceptable AQA performance. For the turnaround time of troponin for the emergency room, we have from a reception in the lab, but also a new one from blood sampling to really capture the full process for our patients. And finally, for the post-analytical phase, the rate of incorrect laboratory reports. So with this, we are getting to the essential, focusing on a patient outcome. And the next level for us is to really be able to provide clear explanation to national societies and labs across the world on what's the benefit for these quality indicators at the patient level and the organization level. Our second and third objectives was to significantly increase the number of labs included in the calculation of quality specification, so our benchmark. And so we wanted to collaborate more closely with national leaders implement this. And I'm sure there's a lot of representative of national leaders in the room right now. So please don't hesitate to reach out so we can collaborate all together. The first strategy we have is we're looking how we can produce global quality specifications. There's some challenging for a national QI comparison program to provide individual data in the IFCC program. So we're trying to find a way so national programs can provide the overall score of a specific QI with the number of participants included, and pulling this all together to end up with thousands of labs included in the calculation. This is a nice project that is co-lead with Dr. Wilson Skolnick and Dr. Alex Gallero from Brazil. The other strategy we have, it's the National Leader Platform. This is a nice platform that was developed by Professor Plebani and Siakovili, where national programs can push in-batch data that are standardized with the IFCC. And I would like to acknowledge the work of Dr. Zorika Sumarak that is working hard to enroll multiple national leaders in the Balkan region. Once again, if you have an interest to join the effort, don't hesitate to contact us. We want to facilitate the process for labs to be able to record laboratory errors and access the data in our LIS, because we know it's not always easy. And this is a very nice project that is in collaboration with the Pre-Analytical Working Group of the EFLM and is co-led with Dr. Ruben Smits from Netherlands. What we're doing right now, we're matching in the main database with the LIS and the line code and SNOMED code, what code are existing for pre-analytical errors, and we want to come up with a clear recommendation of what should be added to have the full pictures when it comes to pre-analytical errors to facilitate the process for all the labs across the world. We also want to have a stronger collaboration with the industry and facilitate the process for our members participating in the QI's comparison program to calculate quality indicators using other softwares and middlewares other than the LIS. And so this is a good example of a collaboration between the WG-LEPS and Siemens Healthineers with the APM solution, where we were able to build a specific dashboard related to key IFCC QIs that are part of the essential panel. And so it's extremely easy for people to access their data, but also to do root cause analysis to be able to improve actively looking at these quality indicators. So please don't hesitate to reach out if you want to collaborate with us on this. We're really open to collaboration. I would like to finish my talk briefly mentioning this project in collaboration with the Canadian Society of Clinical Chemists on the integration of point-of-care quality indicators in the IFCC guidelines. And we were able to publish 2 different papers on that topic, mapping the process of glucose meter, but also identifying standardized quality indicators, so the essential quality indicators for point of care that we should incorporate it in the quality indicators comparison program. So finally, I would like to acknowledge the work of all the members and corresponding members and collaborators of the WG-LEPS. Please don't hesitate to reach out. You have my email address here. We're more than open to collaborate with you guys to push these projects forward. And let's make sure that we always keep the patient in the equation and focus in our work on patient safety and patient outcome. And on this, I would like to wish you a wonderful time in Belgium with a nice general conference and Euromedlab. And please drink Belgian beer for me as well.